Thank you everyone for joining us. It's 12:30, like I said, on the dot, so we're going to get started. My name is Hannah Crouch and I'm the editor here at Digital Health. Thank you to everyone for joining us today and giving up your sacred time of lunchtime on a Friday. But I promise you today's webinar is sure to be an interesting one, as we're going to be looking into how Kettering General Hospital has been utilising CareFlow Connect. And the mobile platform has been used by doctors, nurses and care professionals at the Trust to coordinate care, as well as supporting clinical workflows, which includes text and picture messaging, list management, handovers, task management, alert notifications and referrals. That is a lot. Our speakers today are Dion Rogers, who's a CNIO at the Trust, and Dr. Solange Cerner, who's the Deputy CCIO at Kettering as well. And they'll be sharing their experience of how they've deployed CareFlow Connect during the pandemic. After that, we're going to be having a Q&A session, where listeners can put their questions to the panel. And please do get your questions in. Just a reminder for anyone who does have questions, you can ask them at any point during the webinar, and you can submit them in the Q&A section. So we also have a community vote, so you can give a thumbs up to a question if you like it, and this will sort of higher it up the list and sort of make sure it gets asked. So please do get your questions in. I'm going to stop talking now. I'm going to hand over to our speakers, who will hopefully introduce themselves and do a much better job than me. So it's over to our panel.
Hi, I'm Dion Rogers. I'm a registered nurse here at Kettering General Hospital, and I've been working as a qualified nurse within the county for about 25 years. And last October, I was appointed as the Chief Nursing Information Officer for the Trust. And I've been one of the key stakeholders in the implementation of CareFlow Connect. Solange.
Hi, I'm Solange. I'm one of the Trust Grade Registrars in Gastroenterology at Kettering General. I've been here on and off since I was a FY1, so about 6-7 years now, so know the hospital pretty well. I have had the role of Deputy CCIO for about 6-7 months, and also have been implementing CareFlow Connect alongside Dion.
So thank you all for joining us. We're really proud of our Connect journey as part of our EPR system. Wanted to just talk to you a little bit about where Kettering started. So as I said, I was appointed in October last year. There was a few months before we tendered for an EPR solution and partnered with System C around this. And that was really the beginning. When we were talking about what we should discuss on this webinar, we actually said cavemen. We really didn't have hardly any systems at all to support clinicians, apart from obviously our PAS and our results reporting. Everything else was paper, fax, telephone referrals, etc. So we were starting really, in hindsight now, with a blank piece of paper, which I think is sometimes easier than when you're trying to join other systems. So when I look back, quite a fortunate position actually. So obviously there were national drivers around EPR systems, and in 2017, our digital maturity assessment for the organisation, we were at the bottom basically. We knew we would be, but obviously from there, being a positive organisation, the only way is up really. We had a look at some audits, and 36% of our medication paperwork had errors. We had to change, we had to do something different. So we did tender with System C, and we're now in a 10-year contract with them. We have an aspiration. Some might say this is, unachievable, but actually we're on our way. We're not going to be bottom next time we assess. We do aspire to be the most digital hospital group in England. And when I say group, we have just joined ourselves with a group model with Northampton General Hospital as well. We plan to work with our partners to enable digital care for patients across Northamptonshire, and as well as our EPR procurement, we have partnered with them around our GraphNet, so we're working on the Northamptonshire shared care record as well. So that's a huge ambition, but I hope you'll agree. I think we've got the right attitude to get as far as we can, and hopefully we may be the most digital hospital by 2023. We've got some core aims, and we have something called care values within the organisation, and all of our strategy is based around these care values. So we've broken these down for the digital programme to be enhancing clinical care at our patient's bedside. You know, lots of digital is out there, but actually, is it in the right place where clinicians need to have it? And I often do this, is it there? Is it in their hands? Because that's where they need to have it. Supporting clinical decision making, so making sure they have the information that they need right at their fingertips as well. And it has to be accurate and complete. So as well as applying all of the digital stuff, you know, how can we make automation and stuff coming out of pathology, for example, right there in the clinician's hand as well. Patient flow is obviously always a challenge, and particularly in this year now we've got designated red and green wards for COVID as well. Part of our plan is to make sure that our operational planning and our flow planning is aligned, and hopefully you'll see that Connect helps with that as well. And of course, becoming a paperless hospital. Back in, it was probably about December, our CIO Andy and I met with our Chief Executive Simon, and Simon challenged us to say, how will you know when you've been successful? And I said, when I don't have to bring a pen to work, or when clinical staff, more importantly, on the ground don't have to bring a pen to work, because we're really keen on showing a measure of success that isn't just all about stats and data. It's about what's happening on the ground. So not bringing a pen to work is really important, not having notes overflowing in cupboards and on shelves. And then we're following two sort of hashtag initiatives. One is obviously Purging the pager, that's more national, and paper out of pockets is something that I'm particularly passionate about. That is my measure of success on Connect. You know, getting those bits of paper out of pockets, they are dangerous in terms of confidentiality, and obviously, you know, we have much better systems now, and it's time to move away from that. So over to Solange.
So I'm going to talk to you a bit about our Connect journey and a bit of a background to Kettering General. So as Dion said, when we were discussing this earlier on in the week, we were joking about calling ourselves cavemen, and actually I don't think it is a joke. We really were in the dark ages. I remember coming here I'd trained at Nottingham and everything was electronic, and all of a sudden coming here and finding out that I had to request a chest x-ray on a piece of paper that was colour coordinated. Girls were pink, boys were blue, and if you put it on the wrong bit of paper, it got bounced and you didn't find out for however many hours, and then the x-ray was delayed. And so we really needed to go from there, but we didn't need to take many steps forward to get better. But if you look at our journey, we really have improved. And talking to the F1s that I have now, they can't believe what I went through as an F1, and it really isn't that long ago. So our main aim, as Dion had said, was to get paper out of people's pockets and improve the experience to not only the clinicians, but more importantly, the patients, and improve their outcomes, reduce their delays that they were experiencing, reduce unnecessary tests that were being requested, and get them the care that they needed in a timely fashion. So CareFlow Connect was rolled out officially to all of the doctors in December last year, and even that date was a bit of a struggle as to when we picked it. So we rolled it out on the day of changeover of all the junior doctors in the hospital. And then we rolled out to the nurses and the allied health professionals in March this year, just at the time of COVID, really, just before. And there are now over 2,000 clinicians using Connect. And I have to say, I'm not sure we ever thought that day would come. We got so excited when we had 10, and then when we had 100. And to say here now that we've got over 2,000, it's just truly incredible, especially when we've done this during a pandemic. And so I suppose what we need to reflect on, and I think what's important with our EPR journey, is how has COVID assisted us with that journey, when actually, when it was knocking on our door, we could have said enough is enough and we're not going to take this any further, but actually we used it as a method of helping us progress with our journey. And there are a few processes that Connect allow us to do that have helped us with COVID, and that's the ones outlined on the bottom, which we'll go through a bit later on. So mainly organisational updates, vitals, so observations are integrated into Connect, secure messaging, team updates, COVID alerts, and then the referrals process has also gone live. So there's lots of things that Connect have allowed us to do with COVID.
It's you, Solange.
Oh, is it? I thought, sorry, Dion. So as I was saying, this is our timeline of events, really. The first thing we did is we looked at how were we going to implement Connect into our hospital, and remembering that we were going from a system or an organisation that really didn't have any digital products within it other than PAS and the results reporting. So we created a working group, and the decision was made that we would go live with CareFlow Connect on a pilot ward with a chosen number of doctors, and we would start with simple things first, such as handover and messaging. And that was back in November, and the gastroenterology ward was chosen, so that's my ward, as the medical ward, and we chose orthopaedics for the surgical aspect. After a really successful pilot on our ward, in particular the gastro ward, we then decided to go live with the rest of the hospital. And as I said, that was in December on changeover date. And there, again, a very difficult decision to make as to what day we went live. And we decided that the changeover of doctors was actually a good date to implement a new change, because everything was new to the doctors anyway. And so what was yet another thing to add to their list? And so it was a bit, I'm sure some hospitals would have avoided changeover date like the plague, but we decided that we could harness that and make more of a success. And for us, it really did work. So for those first few weeks, as we went live to other wards, we used multiple floor walking, and we tracked adoption with graphs, and we had various super users that different wards could contact for assistance to go through the various aspects of Connect, how to update a handover, how to message. In January 2020 and on into March, we then looked at getting the rest of the hospital on board. And really that came from the fact that they were seeing that the doctors were doing it, and so they wanted to get involved. The nurses were really keen, well, hang on, if the doctors are using this, why can't I use it? And can we look at getting this out as quickly as possible? It was a tad more complicated to get the nurses involved just because of the way of the nursing handover, and the fact that Connect really does lend itself beautifully to a doctor handover. With a nursing handover, there's obviously a bit more detail that needs adding in there. And so we did create a specialist nursing group to go through with Dion as to what they would like to involve within their handover and how they would implement that on the wards. And again, the fact that we had that group was a real driver to make it work out on the wards, because there was a group of 60 super users that were all contactable throughout the hospital to go to and lean on for further support if you needed it. And then obviously, as we all know, COVID hit us, and we were at the beginning for the nurses and allied health professionals, and at a stage where we really wanted to start looking at adding other things into Connect. And I remember us sitting in a meeting, Dion, and saying, well, do we progress with this? Do we hold this off? Do we progress? What do we choose to go with forward? And what do we say, well, we have to wait till COVID's over? I mean, little did we know then that what we know now. And that there are certain aspects of Connect and our whole digital journey that really did need to be progressed because it would help us. In April, at the height of it all, we introduced inpatient referrals onto Connect into various specialities, starting with dermatology. And then as with everything, gastroenterology seems to be the pilot for most things. So we moved on to cardiology and gastroenterology. And then in June, we made the decision for the whole of the hospital to go on to inpatient referrals via Connect. And we achieved our big handover milestone of 50,000 handovers, which again, back in November, we were getting excited when we'd hit 100. So there was a huge, huge moment. And then really looking at what else happened during the COVID journey and the things that we implemented into Connect to help us along that way. And we were looking at key things that would help our clinicians as they're in the full PPE looking after the COVID patients, and help the site team manage the COVID patients. So we got vitals implemented into Connect and COVID-19 alerts back in June, which allowed the site teams to see whether a patient needed to be in a red area or a green area without having to go onto the ward. So that was a real help. And then in July, we looked at getting the other services onto the referral process. So when we went live with the referrals, we looked at our own inpatient specialities, but we realised, particularly during COVID, that all of these other teams that were involved with us, such as the dietitians and the alcohol liaison team, as soon as COVID hit, they were kicked out the door and weren't allowed onto the wards, but we still needed their support. From a gastro point of view, we really needed the alcohol liaison team because we had multiple people coming in with decompensated liver disease, and we needed that specialist input from that team, and we just weren't getting it. And so the decision was made to go live for their services onto Connect, and they were all of a sudden able to provide support and advice when they hadn't been able to, and that made a huge difference on getting people out of hospital quicker than we'd been able to before. And then I suppose really in August and this month, or the beginning of this month, when COVID had started to die down, we looked at the other things that we could start implementing whilst it was slightly quieter. And so we were looking at our big issues really, or left with the hospital, and that is our complex discharges. I mean, that's a problem no matter where you are in a hospital. There's always that complex patient that needs that bit of added support, and there's always lots of frail people that need that added support from the frailty team. And so we looked at developing tags within the system that were specific to those things. So the complex discharge team, they developed a tag, and the frailty team developed a tag so that they could be highlighted to those teams, and those teams could provide support to the ward. And just this week, we've gone live with referrals out of ED and to all the major specialities as, yes, another thing to add to our bow. And as far as I'm aware, I've just spoken to the project manager this morning. That's going really, really well. And there was a lot of concern about it, I think probably mainly from the surgeons, but actually it's going really well, and I'm very excited to know where that goes within the next few weeks or two, especially as COVID starts to come knocking on our door again. And then where are we looking for in the future? Because with our team, we never turn off. We achieve these milestones and we're on to the next one. We want to hit the next thing. And I think there's a few big things for us that are still problems in Kettering, and that's our ability to look after the hospital at night with our task management of our junior doctors. And number two, when are we going to get these results, such as radiology and blood results, onto Connect? Because at the moment I can get OBS, but I have to log into 2 other systems to get the other 2 things, and you need to have multiple windows open, and it's frustrating on the ward round. So as far as I'm aware, and Dion, correct me if I'm wrong, they're due to come in, results reporting is due to come into Connect in October, so a mere month away. And then the tasks, so that's like jobs, we're looking towards the end of the year, and I really do think that will make a huge difference to the flow of the hospital at night and to the lives of junior doctors who, bless them, at the moment walk around with 150 jobs to handle on Connect handovers. So it's not brilliant, but it's certainly better than 150 jobs on paper. So when those tasks come, it really will make a difference.
Thanks, Solange. Yeah, to add to that, I mean, as you can see, we've done so much over the last year. I had an email from one of our Care the Elderly consultants this week. She emails me regularly, actually, to just tell me how great it is. And this was someone who, she wasn't opposed to technology, but had been working in hospital a long time, and has just said it's probably the biggest transformation that we've seen in many decades, really. So that for me is a big win as well, to see clinicians really utilising it to their benefit. So the way that clinician uses it is before, at the end of the clinic, let's say, she checks on all her inpatients, and before she goes home, she makes sure everything's done and the juniors have got everything in hand. So, you know, some great functionality out there. And I just want to personally thank Steve Gray from Bristol. At the beginning of this journey, we called him and said, have you got any advice? And he said, momentum. keep going. And I think that is why we've done so well, because we really did embrace that concept and listen to that advice. And that's why we're sharing our story now, because actually it should be about sharing lessons. It should be about sharing successes. And Steve said, you know, they had stopped and started, and it's really hard to get going once you stop. So keep going. And we've absolutely stayed honourable to that piece of advice. And as Solange said, that day that, you know, COVID was fast approaching and we said, should we carry on? That was in all of our minds really, as saying, how difficult will it be to get going again? And what benefits could this bring? And let's give it a go. So that's a real big lesson for me through this journey. So we've told you what we've done. There's just some stats here really about how we're going. So as of yesterday, I think 3 more have joined today. I've just had a look. We've got over 2,000 users, as Solange has said. We're actually now at 164,000 handovers. And, you know, counting for us is really significant, because we use these figures to check on our adoption, to make sure that people are doing the handovers and that we're not falling off once the initial buzz of this tool is wearing off. This is actually growing day on day, week on week. And actually the biggest thing for me is that these are multi-professional handovers. So we have 4 profiles: medical, nursing, allied health professional, which is mainly therapists, and pharmacists. We've never had anything all in one place before. Even before, you know, we had some systems on an Excel spreadsheet or on a Word document or paper in pockets. And actually those handovers weren't shared between the disciplines. And I personally think that that has helped people to see what everyone else is doing for the benefit of the patient. Referrals, as Solange has said, have been rolled out. So initially, again, to doctors and then to the rest of the staff nurses, specialist nurses, and some support services. And, you know, we're just over 4,000 referrals now. That's been really interesting, referrals, because we are starting to see how we can use referrals not only to promote patient journeys and people getting the right care at the right time, reducing delays of people coming back, as Solange has said. You know, you sometimes didn't know whether that email has landed in the right place, or God forbid we faxed at one point referrals. And, you know, things are really quick now. When we started with dermatology, our dermatology service is off-site, and obviously when COVID started, rashes that were due to COVID was a new thing. And I don't know why we chose dermatology, probably because it was off-site in the main, but actually having that dermatology service was key. And we were starting to get results back and advice back from the dermatology team within an hour of those referrals going out, which was a huge benefit to patients in the hospital and staff looking after those patients. As far as photos, so a feature that we used we deployed very quickly when COVID started was the photographic function in Connect. The tissue viability nurse contacted me and said, Dion, you know, 50% of my workload as my workforce has gone down. I've got people off sick, people shielding, etc. And they're coming in thick and fast. I don't know what to do. Can you help? So we had a look and revised with the lead nurse for the practice development the process for tissue viability, and decided that we would use Connect. And now that's very, very much embedded. So wound care, whether it's surgical wounds or pressure areas, are now recorded on Connect, sit with a patient record, and the tissue viability team recommend regular photographs to make sure that they can, 1, see things remotely, which has helped their workload, but 2, keep a record of whether the wound is getting better or worse. So there are 4 main successes, I would say, of how things are used in practice. So how did we adopt this? Solange has spoken about the working groups, but we did much more than that off the back of the working groups. So The working group started off with a group of doctors, about 30 of us at one point, I think, Solange, weren't there? You know, we just reached out to people and said, you know, we've got this exciting new project. We think it's going to really help you. Please give us an hour a week. I think pizza was a big factor in that as well. We had a very generous CCIO who used to bring us pizza and cake on occasion. And, you know, we had very, very good commitment from those doctors. So that was the first thing. The second thing, we very quickly started to utilise the data, as Solange said. You know, we celebrated every success when we got 10 on, when we got 100 on. When we got, I think it was when we got 1,000 on, or 500, we found the doctor who was the 500th joiner and gave him a box of chocolates and celebrated it, because, you know, every single bit of achievement we were really proud of. Obviously training, so we then got our training team involved and put on proper training through Microsoft Teams. So then that trainer would reach out to specialist nursing teams in particular. I think it's fair to say that doctors took to referrals in particular and handover very well. And as Solange said, nurses were not quite used to referring in this way, used to picking up the telephone or catching someone in the corridor. And actually we've provided quite a lot of training now to those staff to get their confidence up. And I'm certainly going to be doing a 4-part series for specialist nurses through October around how to get the best out of the systems, because there's so much more we can do. We then mandated it. So our director of nursing and our medical director, very early on, we got engaged, did some one-to-one sessions with them, and, you know, shown them the benefits of this system. And they were really, really supportive and actually mandated the use. Put out updates saying, you know, the use of WhatsApp will not be supported for patient data. It's not safe. It's not secure. You now have a secure platform. We want you to use it. And more than that, you should use it, because it's what we're providing you. And on that, organisational updates, it does have a feature to provide organisational updates. And why I really like this feature is because communicating with clinicians can be very difficult, because they're not sitting behind a desktop, they're not watching screensavers, and they're probably not reading the newsletters that come out every week, but they are looking on Connect. So we now have organisational updates every single day. All our COVID updates go through Connect from the organisation, and our director of nursing and our medical director post regularly updates to staff through this app. We then started to look at adoption reports. So again, using the data, and you know, we're very serious about Connect, and we actually write out to areas that are proving to have dropped off adoption. And they're actually, last week we sent out something and I got 2 phone calls immediately saying, why are we on the naughty step around this? And we're like, you have adopted, but it's not consistent, and you now need to pick this up. And people are very seriously doing that now, because they know it's here to stay and they can see the benefits of it.
So I'm going to talk a bit about how Connect helped us with COVID. And really, if we went back to that first slide when I talked about, I think there are a couple, 6 or 7 aspects of Connect that have really helped us with COVID. And the first one that Dion's just spoken about quite a lot is the updates from the organisation. So what is an update of an organisation, and B, how did that help us? So as you can see from the screenshots, whenever a user logs on to Connect, the first thing you'll see are all the updates from your organisation. And so it could be anything, it could be all the teams you're logged into, it could be photographs, but more importantly, there's also messages that everyone in the whole hospital needs to be aware of. And at the beginning, this was very much used by Professor Chilton and Leanne, the medical director, and the head director of nursing, to give their updates, not only on messages such as, you know, make sure you don't go home in your uniform and the uniform policy, but also congratulations and you're doing really well, team, and there's a bit of a spurring on type comms. And then later on, when we were having issues with PPE, and it was very much rationed isn't the right word, but, you know, staff and wards had to go and collect it, this was our method of making sure that everyone was aware of where they needed to go, what time they needed to collect their PPE, and there was no longer all those phone calls to people that weren't necessarily on the other end of the phone because they were working from home. And this was just a very quick and easy way to make sure that everyone within the hospital, all the clinical staff, are aware as to any mass change or an important thing that affects us all within the hospital. Next slide. So the next key factor that really did affect our working during COVID was that we integrated our vitals, our EOBS scores into Connect. I suppose some people could argue, well, what difference has that had? Why does that matter? But for me as a registrar, I think the key thing that this has allowed me to do is that whenever I'm off the ward and not necessarily sitting next to a computer, I can log into my phone, and we all have our phones next to us, usually at fingertips, and immediately see what's going on in my ward, who's the poorly patient, what's happening. And invariably, I've usually picked it up before the juniors have, and I've rang them and told them this is what we need to do about this patient. The other key thing that we found that I'm not sure we were necessarily expecting at first, but I suppose it's kind of a natural benefit, is that when clinicians were all in PPE and going into these COVID bays and side rooms, that they weren't having to take in with them multiple devices, charts. They were going in with one device, could log in with one click of a button and see exactly what somebody's observations were, what had been the trend for the last, I think it's the last 4 or 5 set of observations, and act on them as required, rather than having to come in and out of the room, on and off that PPE. And so I suppose from that perspective, when PPE was a bit of a scarcity, we were there using minimal PPE and the right amount and doing the things that we needed to do it in one fell swoop. Next slide. The next feature, and this is a feature that we used very early on, is the messaging feature. And again, as Dion alluded to, WhatsApp. Now WhatsApp, I think every clinician in the country uses WhatsApp or use WhatsApp to communicate with their colleagues. Particularly, you know, ward groups have a whole group of a WhatsApp message to talk about patients on the ward, and we realised that actually that isn't the way to communicate. It's never been the way to communicate. It's not a safe way, and we needed to use a secure function to allow us to do that. And again, Connect is pretty self-explanatory. It's very much like WhatsApp, but on a secure platform. Connect allows clinicians to message each other wherever they are. You know, the reality is not all the time your seniors are available on the telephone, but most people can reply to a message pretty quickly. And the juniors really did take to this, as did the nursing staff. I know particularly on my ward, the ward sisters used to message the site team to say, we've looked, gastroenterology do an in-reach type service. So they used to message the site team and say, we've looked on MAU in Clifford's Connect ward and we'd like this patient to come over. And again, saving phone calls, saving people walking over between red and green areas. And I suppose it's a documented evidence that you've had that conversation. Next slide. So the next thing is really the ward and area updates, and very much like organisational updates, we use this again in gastroenterology and on the respiratory wards to convey messages to their team. So with the organisational update, when you convey a message, the whole hospital are seeing that update. But when it's within a team or an area, it's just your team seeing that. So we have on ours, for example, the ward rota for all the juniors to see and to add to. We have guidelines relating to how to manage a patient with alcohol withdrawal. Other wards have looked and have used it for COVID-specific things, again, particularly around PPE, informing staff members, this is the PPE you need and this is when to use PPE, this is when not to use particular PPEs. And we've really found that from a senior perspective, that they've been able to inform a lot of staff very quickly with one message, rather than having to wait for ward meetings or emails that people don't necessarily have access to. where they're not on site. Next slide. COVID-19 alerts. Now this, I suppose people could say, well, what's this all about? You can log on to the results reporting and find this out very easily. Well, you can, but this came on your phone in real time. You'd sit there, you know, I've got my phone next to me right now. You sit there, if it pings up, it would tell you whether somebody had a COVID positive result. And so that was really used by the staff team and those on the front door, the infection control team as well, to be able to create an accurate list of patients that had COVID. And with that list, to track where they went within the hospital. So if somebody came back positive, we knew that they needed to be on a red ward in the appropriate environment. They didn't need to be out on a green ward. And if they happened to be on a green ward, the site team were alerted immediately, infection control team were alerted immediately, and the patient could be moved to where they needed to be and get the appropriate treatment. So it was that immediate action that allowed clinicians to give patients the best treatment and what really was a terrifying time back then. And we were really finding our feet with these things, but you know, I remember we used to get lots and lots per day coming up on the phone as COVID positive. And invariably, before I'd even said anything, the site team and the infection control team had known about it and something had already been actioned. Next slide. And then on to digital referrals. And for me, this has really changed my day-to-day working. And I think the exciting thing is now that we've gone into A&E and seeing where that goes. As a gastroenterology registrar, we get multiple referrals each day. Some of them are urgent, such as the GI bleeds, they're emergency, and some of them are less urgent. And in the height of COVID, those less urgent ones, you don't always need to go and see the patient. And we were trying to prevent people from crossing between red and green areas, and this really did allow us to do this. So from a medical perspective, we started with dermatology. And as Dion alluded to, when COVID hit, everyone had these weird and wonderful rashes that we needed the dermatology team to have a look at. And not only were we preventing a team that weren't on site from coming in, but actually we were saving a patient from getting in an ambulance and having to travel 3-4 miles up the road up to the dermatology team and then back again, just because we could now take a picture and get instantaneous advice. And I think, as Dion said, the dermatology team were replying back in a matter of minutes usually, and we really did notice how quick those referrals were being responded to. And time is a wonderful thing, you know, saying somebody replied back in a minute, that's a great stat to throw around, but what did that mean for the patient? Well, it meant that somebody that could potentially go home now was able to go home that day because we'd had an answer from that team and they weren't waiting a day or two. And Dion talked about fax earlier. I remember as an F1 having to fax things and I didn't have a clue how to fax. And I had, you know, you never knew whether your fax got there. You never knew whether somebody had actually read it or acted upon it. Now with Connect, I can see all of that in a click of a button. And I can also see that the advice that's been given before me, or indeed I can make sure that the team are adhering to any advice that I've given because there is that full audit trail. And once doctors had got on board, we realised that the nursing teams also wanted to get on board and how much help could that provide. And as Dion said, there was a time when the whole 50% of the tissue viability team were down, they were isolating or shielding because of COVID, and we couldn't stop having our tissue viability team working just because 50% of them weren't here. We needed a way to keep that service and keep helping the patients that we needed to help. And all of a sudden we found that, you know, in a click of a button, this team really did take over with Connect, and they really do, they've taken it on board and it's ingrained within them now. And we've realised that even though COVID isn't still, you know, well, it is now knocking on the door, but that time when COVID wasn't here, these things haven't just disappeared. People are still using referrals. They are still referring to these teams that now they are back on site. We haven't reverted back to our old practice. We've continued as we have set the precedents during COVID, and we've realised that actually the new behaviour is the better behaviour, and the patients are getting the best with this rather than our old practices. Next slide.
Thanks, Solange. Just to go back over what Solange just said about referrals, I had a call from our lead nurse for palliative care a couple of weeks ago to discuss about another initiative. And, you know, she couldn't believe that the quality of referrals has improved so much as well through the use of Connect. So she told me, and I said, you know, how is this helping you and how is this helping patients? And she's just said it was just so much better because we've laid out how people want to be referred in a standardised way and what information they need to provide. We've done a training guide for them. And actually, she said, I can now see what patients I need to see and I can prioritise them much quicker. I don't have to go to the ward or look in the notes. And that manifests in patients in pain being the first that she would see. And so she believes that this has actually helped people become pain-free quicker, which is a phenomenal measure actually of success. So this is about some other clinicians giving us feedback as well. So one of the things that quite a number of our nurses have said is that it really has helped with handover, eliminating the paper. Things aren't lost. So at the very beginning of this, I did some research about handover and found that between 20 and 40% of clinical incidents are due to misinformation, miscommunication. And the recommendation was to have a standardised documented handover. And so I definitely think I'm doing some work on looking at the quality of this at the moment, but definitely it feels like information is much richer and much more consistent. So that's been a big win. Leah Houghton, who's one of our sisters on our Pretty ward, Pretty is named after Harold Pretty, who was an orthopaedic surgeon many years ago, said that she really likes the alert functionality and the ability to get messages. She needed to ask medical team to do something the other day, but didn't warrant disturbing them. So it was sort of like a to do, but not right at the moment. Passed the message to the doctor through Connect and was able to allocate the task. So she just feels like teamwork has been improved and that everything is logged and auditable. Convenience. So one of the things that I see we've got a lot of questions coming is what devices did we use? So we took a decision to promote bring your own device. We set up a bring your own device Wi-Fi, and that was brilliant actually. So we've now got a number of staff using that, and we've passed through our policy. Because this app sits in the cloud, people can have it on their own phone. 75% of people are using it on a mobile device rather than a desktop. We have got iPods in all of the ward areas that we have vitals on. People can access it on the wards through that. We did also put 15 devices in our site office for those who didn't want to use their own device, but I can't think of anybody who's actually picked one of those up. People are either using the hardware that we supply on the wards or they're using their own phones. And I guess this is probably my favourite quote really, is Connect got me through COVID. So Holly is our infection lead nurse, and she joined the trust in March. I mean, great timing, to join a new organisation at the beginning of a pandemic as a lead nurse. And I knew Holly from a previous organisation and touched base with her, and she just said she was shocked at how limited the technology was and that she couldn't find information out. And very, very quickly, once we got onto Connect through March, that rapidly changed. And she just said now we are actually going to write Holly's story, because she just said it has just made such a difference. And again, things like the things that Solange said, you know, don't have to go to the ward to look through the notes. You can instantly message clinicians and updates and advice. And we're looking at even more ways now that Holly and the team can have improvements on their workflows through Connect and our other systems. So benefits wise, Solange has talked about quite a lot of benefits, but we wanted to really talk to you about some lessons that we'd had. So, you know, when we started this journey within the working group, I think a very quick realisation was this is not deployment of a digital system. This is problem solving the issues that we have in the trust. And that's the kind of place that we came from, is saying, what are our problems that we're trying to solve? And that actually led us to our strategy about messaging and handover. We knew that we didn't have a good system for basic communication. So that's where we built on, really. And so what are the benefits? Absolutely, that was our first priority. Persistence, as I've said to you, that momentum word and being persistent with this, we haven't stopped. And we're very lucky to have an organisation that is really behind us. This organisation was ready for digital. As I say, we didn't have a lot, but we've been brave. We've been brave around this, and we've worked very closely with all our clinical teams. We've got a very strong clinical team. There's 6 of us, all doing different types of hours. There's 2 of us in full-time roles, and our doctors, so our CCIOs and deputy CCIOs, retain clinical shifts and have some hours per week to support us with a digital programme. But having that commitment and that framework from clinical staff has been absolutely key. System C partnership. I mean, we really have developed some really good working relationships with System C. You know, we're not a shy trust. We have said, this isn't good enough. Can you please develop this? Can you make this enhancement? And but we've always done it from a point of view as this will really help in explaining why we want this, what the benefit will be for patients and staff. And we've started to now get some enhancements that we've put in, and it's really good to see that partnership thriving. Super users and digital champions, as Solange said earlier, you know, that first working group, having those super users on board, we couldn't have done it without them. Actually having those people on the ground promoting this. Communication is really, really difficult, as I said, for staff, and we didn't have Connect to communicate with. So we needed those people on the ground really believing in this and really helping us drive it on a daily basis. And I can think of people, you know, Solange in particular, but then Arish and Faisal and Gaurav, you know, they were all out there every day, as well as doing their clinical jobs, helping us to promote Connect. Senior leadership support, as I said earlier, you know, that's, if I was going to do anything again, it would definitely be to get the senior leadership team on board very early. Solange and I go monthly now to the Junior Doctors Forum. We have a standing agenda item on there to make sure that anything new is communicated through really well. And my colleague attends the nursing and midwifery group as well. So really getting that senior leadership support was essential. And then training, I have to mention our IT training team, who are phenomenal. So we've now got bespoke online training packages. We have sessions that can be delivered over Microsoft Teams, and our videos, we've got videos and user guides and stuff to support all of this. So we've got a very robust intranet page that people can find out whichever learning style they have on how to train. And finally, just wanted to finish with this quote. So Dr. Phil Watt is our clinical lead for ITU, and you know, I think has pretty much had the toughest job in the hospital going through. And ITU were one of our really early adopters on handover using COVID, and they just were phenomenal at it even before. But during COVID, we noticed that they'd increased their usage by 400%. And you can see what Dr. Watt said on the slide there, that it's proved invaluable, and you know, it's very much sustained. They're one of our best users of Connect. It's very, very much embedded. And you know, when I spoke to Dr. Watt, it was again, like Solange just said, you know, having this system where you could be in full PPE and just have, you know, a place to document something on your phone. We couldn't bring paper into those areas because, you know, we didn't know whether it would be carried on paper, etc. So absolutely has been rubber stamped by Dr. Phil Watt, which is great. Anything you want to add to that, Solange? Okay, thank you so much for listening. I can see we've got lots and lots of questions, so we'll have a quick drink and then get over some questions. Thank you.
Thanks so much, both. I think it's a lovely photo as well at the end. I think it kind of summarises the last couple of months for everyone. Yeah, excellent presentation. We've had so many questions come in, so I'm not going to waste any time. I think you've already answered the the most upvoted one about the devices. So they said about, do you provide devices as a trust or staff use their own? And from what you said, it seems to be a mix. Is that what?
Yeah.
Mix of bringing their own and some on site as well?
Yeah, so
sorry, I was about to say, I also think it's really important to add that when we were discussing this, we had a lot of backlash from doctors at the beginning, because one of our trusts within the region where a lot of the doctors rotate from, so Leicester, they get given a device when they go onto the wards. And so that was the expectation of the juniors. And so we made the decision to put some devices in the site office that were available for the juniors to use. And very quickly, the juniors decided that they didn't want the device. They wanted it on their phone. And I would say in a week or two, every junior doctor had the app downloaded on their phone and were using it. And I don't think the devices inside have ever been touched to this day. So I think you'll receive, we received a lot of backlash at the beginning. We were talking about how are they going to get compensated for this? We're going to pay for their mobile phone. But actually that died down very quickly. And we stood our ground, really. We did take a major risk not having the devices, but it was actually the way forward, and it was the right thing to do.
Yeah, I mean, speaking to a few of the staff, people get used to their own device and how it works, and the devices we were supplying within the trust were quite often a different device to what people were using, and we sort of discussed it and said, do people really want to carry two devices? I was given a trust device and very quickly gave it back and said I just want to use the same device. And we knew with things like Office 365 coming, where you can get your emails on your own phone and things, kind of having a trust device was probably something that we didn't want to do. So you're absolutely right. I remember having some people saying to me, you can't make me use my, no, absolutely not. We're giving you an option. And that's for me how we've got, such a great uptake, that there is a wide variety of options on how to access Connect.
Yeah, I think it's always good to have the option.
Yeah.
Next question we've got up is, have you replaced non-emergency bleeps with CareFlow Connect?
Not yet.
Not yet. That's a nice simple one.
Not yet. We're certainly reducing bleeps through Connect. Emergency bleeps are still there. We are having a look incrementally at that, but we didn't want to do anything as drastic as that at the beginning of this journey. That's very much probably the end of the Connect project. We'll have a look at that. Yeah.
And another one that's come through is about, is there a preferred type of device, or is it kind of, it's just like you said, if people are using their own phones, I guess it's probably just a mix, isn't it?
Solange?
I think most people do use it on their own phones. When we do the ward round, we tend to log in for the whole team, the computer on wheels. The nursing staff have it on their Vitals iPod device. But most people are using the app on their own phones, and that, I would say, is the majority of people are doing that.
And I guess, is it kind of compatible, I'm guessing, with like iPhones and Google Play and all those types of things? Yeah. Another question is, and one I was actually going to put to you, how have staff responded to working more digitally? Sorry, has it been positive? I know you gave some examples, but what's kind of been the generic response?
Do you want me to answer that?
Yeah, I mean, I was just going to say, I think it's been exceptionally positive. As with anything change, most people, you always get the odd person that's moaning and whinging and they don't change. But actually, on the whole, I would say it's been exceptionally positive as an organisation.
Yeah, I've been running a programme called Digital within the organisation, and during, I think it was June, we put out a staff survey about people's confidence and how they wanted to be trained and what the gaps were. We actually got a very positive response back from that, but that we did identify a few groups of staff. Bearing in mind this is a clinical app, the groups of staff that said they weren't that confident with digital was our housekeepers, estate staff and healthcare assistants. So we've been doing some sessions called IT, which is I with a TEA, a cup of tea. We have something called the Care Cafe, and I've been running sessions over Microsoft Teams for our shielding staff or people working from home as well, to sort of do that hand holding really. Not everybody loves digital, as Solange said, but quite often when they learn a new skill, I think we talked about that earlier, Hannah, you know, it's quite a feeling when you can join the rest of the gang really, and know that actually I can use this, I don't need to be scared of it. But sometimes you do need that hand holding, and I think the way that we've deployed Connect, as I say, with the super users has been really successful, because it's not been like train on this, use it. I don't think the training is the biggest part of it. It's the how do I use this question in practice? When do I update this? How do I use this? Is it safe? You know, what happens if I take a photograph on my own phone? And am I going to get the sack? You know, because I've been told for years. I mean, I remember going around the organisation taking down posters that said no mobile phones in this area, because it wasn't that long ago that we said phones would corrupt all the machines in the area. So, you know, and we put posters around everywhere saying, I'm not on my mobile phone, I'm updating your care record. Because, you know, importantly, we wanted patients to see that we weren't being unprofessional on our own devices, that this was part of their care record.
Yeah, I've heard that quite a few times about clinicians worried that they look like they're just probably scrolling through Facebook or something like that.
Yeah.
And then I guess one question is about issues with Wi-Fi. So obviously you're kind of reliant on having a good Wi-Fi system. Have you had any issues, and how, if you have or if you haven't, how have you kind of dealt with that problem?
We have had issues. Absolutely had issues. We're working all the time on improving our Wi-Fi. We've done Wi-Fi studies, you know, we regularly, our IT team check the Wi-Fi, etc. We've had some downtime. We do have a BCP solution with Connect that basically sort of puts the file in the hands of IT that the site team can then access and print out. And we've had one outage so far where we tested that. It wasn't brilliant. We need to test it again. But actually it was down for a very short amount of time. And, you know, we've really had some very open conversations with System C as saying, you know, we're so heavily reliant on this now. We need to make sure our BCP solutions very well ingrained. But as we go with more, so we've now got patient flow that Connect is due to join with in the new year, and all of these modules will join together. We're very fortunate, as I say, to have started from a place where we didn't have to remove one system in order to put one in, and I think, you know, that's really helped us as well.
And for me, actually, when we had that downtime, that was the moment that I realised that Connect really had truly implemented, because Friday afternoon, just before handover, and I remember my poor F1 really frazzled and stressed out as to how on earth he was going to hand over the jobs to the medical on-call team, and what was he going to do. And that was, I was like, well, actually, we've done our job, we've succeeded, because it's so ingrained in people now that they're worried about this, and they couldn't think back to the old days of when we just rang them and they wrote it down on a bit of paper. So actually, I think the downtime was as a positive, because it made us realise how far we'd come.
Yeah.
One question is about how do you manage locums on Connect? I'm not sure if you can do.
So we have locum packs for Connect, but really doctors' locums we know in advance, and we get them on board before they join in the main, and then the super users really would get locums on wards. For nurses, agency nurses has proved quite a difficult challenge, because in order to have access to Connect you need a .net email address, and they're not NHS staff. But actually we've come up with a way of doing that. So they now do the online training on Connect. They sign up to the user agreement, and we now give them basically an email address to get onto our intranet and invite them to Connect, and then review that. We have a time frame on, if that's not used after 30 days, they would be removed. So we're just starting out on that journey. We've got our first 10 agency nurses. So whilst we've been doing that, we've had to use printouts for their handovers, which has obviously stuck in my throat quite a lot with wanting all this paper out of pockets. You know, we wanted to get the process right and correct and robust and sustainable. So we've taken a while to come to that conclusion. But yeah, got our first 10 agency nurses on.
Another one is about how the importance of clinical system integration, and how can you capture on your EPR system issues managed via CareFlow Connect? If that's something you can answer.
Not quite a question.
Okay, I think we'll move on to the next one.
Sorry, no.
The next one's to do with information governance and consent issues when using the embedded photo functionality. How do you kind of deal with that?
So consent is obviously the same regardless of what platform you put it onto. So it's explaining to the patient, checking if they've got mental capacity to give consent for that. We can write on Connect, given consent, we can document it in the notes, given consent. If someone doesn't have consent, then a decision will be made by the clinical team and the next of kin, if they're available, if it's appropriate in the best interest of the patient. So if you have a patient that has a really severe wound and needs that expert help, and the tissue viability team or the surgical team can't come onto that ward because it's a red area or whatever, then we would make a decision that would be documented in the notes under a capacity assessment.
I think we'll probably just take 2 more because I'm worried we're running over. Just anyone that has submitted questions, we will put them to the panel and kind of get back to you via email, but I'll just ask a couple more. One I think is quite interesting. How did you manage go live support during COVID? I think this has been quite interesting that we've been looking at recently as well.
Really Microsoft Teams, as most of our training has been done through Microsoft Teams and adoption. And as I say, we had clinical staff as super users on the ground, and that's how we did it. Lots and lots of touching base with people, quick short training programs, user guides, and use of Connect itself. Really, anything?
I think the other thing is that actually this was ingrained in doctors before COVID hit, so we already had, you know, a percentage of the workforce using it and knowing what they were doing, and doctors really weren't trained. It just had, you know what, I remember the day we went live on our ward, I took all the paper away and said, we're never doing a paper handover again, we will use Connect. And by the end of the week, they were able to use it, and it just disseminated from there, because as my doctor moved on to a different ward, they took that practice onto that ward. And so the doctors knew exactly how to use it. And so as the nursing staff started to use it, and they were coming to us with questions of, oh, well, Sandra, I'm not too sure how you do a referral. Can you quickly show me? 5-minute job, you've shown them how to do it, and then they've learnt, and then they're handing that process on to the next person. So really, a lot of it was on the ground teaching and learning between the staff rather than didactic type teaching.
And it's very, very intuitive.
Yeah.
You know, saying things to people, like the updates page is a bit like Facebook, and the messaging is a bit like WhatsApp, using that common language that people understand. You know, highly intuitive system, and supported that with some one-pagers, like some one-pager how-to guides rather than a massive manual. You know, I think it's about eating the elephant, you know, small bite-sized chunks.
And then I promise I'll do one final one. One question is about how have you demonstrated improvements to patient outcomes?
Lots of ways, really. So we're starting to use the data. We're building a lot of dashboards at the minute. We just procured Power BI, so we're doing a lot of pulling that together at the moment. A lot of this has been anecdotal at the moment because, you know, we haven't had the usual governance meetings going on and in the same frequency and things that we're doing. But certainly one thing that I do is we have a governance report that comes out weekly, and that is all looking at all our complaints and datexes and everything, and I monitor that every week to see if we're building any themes. One of the weeks we looked at, and handover, we've had 2 datexes about handover, but actually when I looked into it, it was transfers between ward areas rather than the shift-to-shift handover. So then we're starting to think, well, can we do something with Connect to solve that problem now? So I guess what we're doing is looking for the problems and then celebrating the moments of success. But in all honesty, we haven't had an awful lot of time to sit down and pull the data out yet. But I'd say within the next month, we'll start to demonstrate that. And we're seeing a lot of good stuff out of referrals at the moment. I've been to a couple of governance meetings to promote that. looking at, you know, the declined rates and things to make sure that we're not, you know, using it for the wrong purposes, or we can do further training with medics and nurses around appropriate referrals.
Have you got anything to add, Solange? Or?
No, I agree entirely with what Dion said.
Lovely. Well, I think we're going to have to wrap it up there. I think we've been speaking for more than an hour. Thank you to everyone who's tuned into today's webinar. Just a reminder, we at Digital Health got a packed schedule in the next few weeks. So please make sure you go to our events page and register for all of them. And they're all brilliant. And a huge thank you to our presenters for their brilliant presentation. We've had so many questions come through. And like I said, we will put them to our panelists and get back to you guys via email. But thank you to everyone for tuning in, and thanks to Dion and Solange. And yeah, I think that about concludes today's webinar. Thank you very much.
Our pleasure. Thank you.
Thank you.
Thanks, everyone.
Bye.
Bye.